Hello. It is my great pleasure to introduce Professor Marm Kilpatrick, who has had a remarkable career combining quantitative ecology, conservation biology, and epidemiology to make important contributions to both basic science and policy. In putting together this introduction, I've had the very humbling experience of trying to distill Marm's CV down to just a few brief highlights. And so here I go. Marm received his PhD in 2003 from the University of Wisconsin in Madison and joined the faculty at UC Santa Cruz in 2008. He has published more than 100 papers, many of which appear not just in top-tier science journals like Science and Nature and Proceedings of the National Academy, but major medical journals like Lancet. This work has been covered by non-fake news outlets on TV and radio, as well as dozens of print periodicals ranging from the New York Times to Scientific American. This work has been supported by diverse agencies, including the Fish and Wildlife Service, the National Science Foundation, the National Institutes of Health, the Center for Disease Control, and the Navy. But one of the most remarkable things about Marm is that he's not just a smart guy doing great research, he's actively engaged in using science to guide policy. To that end, he's served on more than a dozen expert panels, including providing advice to the Department of Defense, the Defense Intelligence Agency, as well as testifying before Congress. Now, no one was an expert on COVID-19 before February, but Marm has rapidly become so. He's part of a team developing testing capacity for COVID-19 within Santa Cruz County. He serves as science advisor to an economic recovery group for Santa Cruz County and does quite a bit of research or science communication through interviews with NPR, the San Francisco Chronicle, and has forthcoming articles in Slate and American Scientists. And despite all this, he's still a really nice guy. Now, a few housekeeping things before I let Marm take over. We are using a webinar tool today, so there is no chat function. If you have questions, you should submit them through the Q&A box in the upper right corner, and do that at any time through the talk. But Marm will answer questions at the end of his talk for about 30 minutes. And then we'll have a short break, and anybody who's interested for more in-depth discussion can come back around come back after that. So one last thing, this event is being recorded, and I hope you all join me in welcoming Marm.
Thank you very much, Steve, and thank you everyone for joining us this morning. So today I'm going to try to talk about the scientific basis for what we know, and quite importantly, what we don't know about COVID-19 and the exit strategy that provides from the lockdowns that many of us have been experiencing for the last few months. So I want to just start by just making it clear how bad it can get. And so in New York City, which has a population of 8.4 million people, the number of COVID-19 deaths as of last night was 21,003. And those numbers are just a couple big numbers, so I don't think that's easy for most of our brains to understand the magnitude of that. But if you do the simple division, that suggests that 1 out of every 400 people that were alive in New York City 2 months ago are now dead from COVID-19. And to me, that's a pretty astounding statistic. In Santa Cruz, that same level of transmission, if that occurred in Santa Cruz County, would result in almost 700 deaths in a 2-month period. So to me, that seems a really enormous impact on our populations. So many people have said, but New York City is special, right? And of course, New York City is special in some ways, but in fact, New York City is not actually especially hard hit. It doesn't actually make the top 10 counties in the US with the highest incidence of COVID-19. And that may shock you, but that's in fact what the data show. And New York Times has a nice website with this data on it that show that in fact, none of the top 10 counties in terms of incidence are in New York City. Okay, so you might also ask, why wasn't Santa Cruz and many other areas as badly affected as New York City was by COVID-19? And the answer to that is quite long, but a short version is that we had early control efforts, excuse me, and a bit of luck. And I'll talk in detail about what that luck part means. So today's goals are that, as I see it, there's a nearly infinite amount of information on COVID-19 between scientific articles as well as press articles about scientific articles. Unfortunately, not all the information that's available is reliable, even if it's published in a seemingly reputable source. So there are articles in what I would consider top-tier press outlets that actually have very, very problematic information that's not based on available data. The slight positive side is that they're often published as opinion articles, but nonetheless, they can be very misleading. In addition to that, there's new information available daily, and I mean daily, or even I should say every minute. And I think a fair question is how should we actually safely absorb this information, and how do we properly discount unreliable information? So with those challenges in mind, my two goals for today are to state what is known and what isn't known based on the science that's available for several what I think are key topics. I'll try to differentiate or be clear about some things we have enough data and we can make relatively strong conclusions, and more data that comes in the future are relatively unlikely to change our overall understanding of how things work. In contrast, there are other topics for which we have very preliminary data, and we have some understanding, but that could change substantially. And there are a few topics, unfortunately, where we know almost nothing at all. And of course, there our understanding is changing every day. In addition to that, I'm going to try to provide a few tools for us to critically assess new information, so that when you guys see new articles coming out in the press, you can actually properly interpret those and not get caught by maybe a flashy headline and be misled by that. So to really convey the information that I want to try to communicate today, I'm going to need to use a few words that are not part of the normal vocabulary of most of us. And so I want to put those up front and try to make them very clear. So the first is that SARS coronavirus 2 is the virus, the actual virus that causes the disease COVID-19. And so you'll sometimes hear me switching back and forth between talking about the virus or talking about the disease. And I wanted to make it clear that one is the virus and one's the disease, the set of symptoms in people. Second, I'll use the word seroprevalence, and that refers to the fraction of people that have antibodies to the virus, and that generally occurs from previous exposure until we have a vaccine. Third, I'll talk about the attack rate, and the attack rate is the fraction of the population that is infected during an epidemic. And so that will be expressed in a number like 50%. So that can be measured at the end of an epidemic or during the epidemic as well. I'll also use something called the reproductive number of the pathogen, which is often described with R sub T or RT. And this is a really crucial concept, and it refers to the number of cases that each case infects. You may have heard, and I may say today during the talk, I may refer to R naught or R0, which is basically the value of RT at the beginning of an epidemic, whereas in contrast, RT is the same idea or the same concept at any time during the epidemic. And I want to make it clear that RT is simply equal to this number of cases per case at the beginning of the epidemic, which is what R0 or R naught is, multiplied by the fraction of the population that's susceptible. So I hope that's the most math I'm going to try to convey today. So this concept is really fundamental to many things I'm going to discuss today. And I want to make it clear that this idea of the number of cases that each case goes on to infect can describe both a population level average, or it can describe the number of cases that a single case goes on to, so an individual value. What's underlying this kind of quantity, this reproductive number RT, is it's equal to the contact rate of individuals multiplied by the probability of infection given contact, and then multiplied by the duration of infectiousness. And things that alter any of those three things can alter this reproductive number of the pathogen. So it's going to come up so many times today that I want to briefly tell us why we care and use RT or R0 so much. And so it turns out if we have a value for this reproductive number RT, the number of cases per case, we can calculate how many cases we are likely to expect in the near future, and that's until RT changes due to changes in behavior or immunity in the population. And so, for example, and this is key, I'm going to talk about this many times, if the reproductive number for COVID-19 is 2.5, which is about more or less in the middle of the estimates that we've seen from different populations, after one kind of generation of cases, which is often referred to as either the serial interval or the generation time, which is about 4 to 7 days for this virus, there will be 2.5 times as many cases as there were at the beginning. So let me say that again. If the reproductive number is 2.5, basically the number of cases will multiply by 2.5 each generation of infection. Crucially, if RT is less than 1, the number of cases will shrink, whereas if RT is greater than 1, the number of cases will grow. If we have a value for R naught, it turns out we can also estimate two other very important things. First of all, we can estimate what fraction of the population will likely be infected during an epidemic without control efforts, and that's been called that's the attack rate I referred to earlier. And we can basically get that by solving this transcendental equation that's shown there. And so for SARS coronavirus 2, there's some complications that I'll talk about in the Q&A if people ask, but that number is estimated to be between 30 and 70%, and I'll sometimes refer to kind of a midpoint value of that of around 50%. So that is the fraction of people that would likely get exposed to this virus if we had no control efforts and did no social distancing. In addition, if we have an estimate of the reproductive number R naught of the pathogen, we can calculate something called the herd immunity threshold, which I'll talk about later as well, which is the fraction of the population that we need to have immunity in order to make the reproductive number equal to or less than 1. Okay, so that's the terminology and stuff and concepts that I'll need to use to describe the rest of the talk. So I want to start out by answering the question, how deadly is COVID-19? And unfortunately, I would argue that there's been a giant misunderstanding in what the fatality of COVID-19 is, and that's because of a confusion between two quantities or numbers that I'll talk about in detail. So there's something called the case fatality rate that many of you hopefully have heard of, and there's something called the infection fatality rate. And these are different things, and unfortunately they're often used interchangeably, and they are not. So the case fatality rate is the fraction of confirmed cases that die. As you hopefully can gather from my underlined and capitalized word, this basically measures the number of confirmed cases, which are the people that test positive for the virus. But because testing has been very limited both in the US and other places, and the testing criteria changes over time and places, that means that the case fatality rate can be very variable, and I would argue it's nearly useless. In contrast, the infection fatality rate, which is the fraction of all people that are infected that die, put another way, that's the chance that you will die if you are infected. That's exactly what we actually want to know. And although this does vary with age and other characteristics like pre-existing conditions, it does not change with the testing criteria or testing capacity. It can be calculated both at the individual level for a given kind of slice of the population, so a given age distribution or a set of conditions, and we can also calculate it for an entire population if we have information on the population's age distributions. So given these two concepts, it's frustrating to me that I would bet that almost all of you in the audience have only ever heard values reported for the case fatality rate and never for the infection fatality rate, even though the IFR is what you want to know, and the CFR is almost useless. So you might say, why is that? And the answer is because the infection fatality rate is much harder to estimate. You somehow need an estimate of all infections, whereas in contrast, the case fatality rate is actually relatively easy to estimate. You just need to count the number of people that you've tested positive, and those become cases, and then count deaths. I should note that for both of these, you need to count the number of deaths due to COVID-19, and that by itself is actually not trivial to count accurately, and there are issues associated with that I'd be happy to discuss in the Q&A. However, we can actually estimate all infections in one of two ways, either from repeated testing of entire population or from a seroprevalence study, which I referred to earlier. That's the fraction of people that are infected based on antibodies in their blood. Testing an entire population repeatedly is difficult, but occasionally circumstances allow us to do that. And the most famous example are cruise ships. So as many of you have probably heard, there was a cruise ship that was stuck off of Japan, and that population was tested repeatedly for the virus. And using that data, and as I said before, because the infection fatality rate varies with age and other characteristics, if we take the data from that cruise ship and then adjust it for a larger population that we actually have good data on the age distribution, that gives an estimate of the infection fatality rate of 0.66% with an uncertainty interval between 0.4% and 1.3%. Additional data more recently from seroprevalence studies, for example, from New York City, which showed that approximately 21% of people in the city had antibodies, suggests that the infection fatality ratio is around 0.87%, which of course is inside that interval that I gave you just a minute ago. So that's a single value, which actually is not that meaningful for an individual person. And so thankfully, there have been a couple recent studies that have suggested, provided estimates of the infection fatality ratio for COVID-19 for different age groups. And so what I've shown on this slide are those individual values. And so if you want to get a number to roughly reflect your own possible chance of dying given infection, and that's what we're looking at here, those are the values there. I should say two other things. One is that these are strictly age-based, is what I'm showing here, but there have been shown to be other factors that also could influence this. And the first that I've listed here is that there appears to be a difference among men and women, in that men appear to be 1.5 to 3 times more likely to die given infection than women, even after accounting for age. In addition, many of you have also probably heard that other illnesses can also increase the chance of dying given infection, and sometimes by as much as 3 times higher. And the ones that are most dangerous are obesity, severe diabetes, and some forms of cancer. So let me just say briefly that there are some ways that we really do not want to use to estimate the fatality of a disease, and yet these are done all the time, including in very prominent press outlets. And what we don't want to do is calculate the case fatality ratio, which I've already said is not a good measure of the fatality or deadliness of this disease. And we definitely don't want to do it using the number of cases, the number of deaths divided by the number of cases. That actually should be flipped. I just noticed an error at any one point during the epidemic. And so the reason this is a problem is because for most diseases, there's a delay between becoming a case and death happening. And that's often substantial. For COVID-19, it's about 2 weeks. And the problem with that is that during an epidemic, when the number of cases there are a number of new cases occurring, those new cases have been reported and become cases yet, but they have not yet become, they have not yet died. And so an estimate of the case fatality ratio using this simple ratio will be too low. We can get around that by either using cases with known outcomes, or we can wait till the end of an epidemic, but of course we often want to know earlier than that. So this is why if you guys see reports that simply report the case fatality ratio as the number of deaths divided by the number of cases at any one point in time, this is a terrible idea. In addition to that, we shouldn't really use case fatality ratio as an indicator of fatality at all because of all the things I just went through. So now that we know something about the deadliness of COVID-19, we can ask, is it just like the flu? And this question has been raised many times. So I'm going to give you a couple sets of data to indicate that's not the case. So for example, the US annual influenza deaths in the last 10 years were between 12,000 and 61,000. The COVID-19 deaths in just the last 2 months, with lockdowns imposed in many and most states, has been 93,408. So that's already 50% higher than the highest flu season in the past 10 years, and that was despite there being lockdowns in all these different places. So that's the first data point that suggests it's not just like the flu. In fact, I will argue that COVID-19 without control and without social distancing would cause at least 15 times the average number of deaths that seasonal flu causes. And where that number comes from is that the number of deaths for a disease is equal to the attack rate, the fraction that get infected, multiplied by the infection fatality rate, which I just spent time giving you a value for. So for COVID-19, given a value of R0 between 2 and 3 without interventions, I told you before would be about 30 to 70%, and that's 3 to 5 times the annual seasonal flu attack rate, which is between 10 and 15%. The infection fatality ratio for COVID-19 is, as I told you before, is between 0.5% and 1%, and that's about 5 to 10 times the flu infection fatality ratio, which is between 0.5 and 0.7%. So COVID-19 would cause 15 to 30 times more deaths than the flu because, in part, 3 to 5 times more people would get infected, and because it's 5 to 10 times more deadly. And so if you do the simple math, as I said a minute ago, seasonal flu in the US causes basically between 10 or 20 and 60,000 deaths per year. If we multiply that number by 15, we'll get a number between 600,000 and 1.2 million deaths. In addition, COVID-19 has a higher ratio of hospitalizations per infection than the flu, so that's an additional strain on the healthcare system. So I hope I've convinced you that COVID-19 is much worse than the flu, and now I think the crucial question would be, how can I avoid getting infected? So what I want us to really take home here is that we actually know quite a bit now about how how SARS coronavirus 2 is transmitted. It's based on what we call contact tracing of thousands of cases. And the idea there is basically when a person comes to the hospital, we try to identify where they got infected and how. And so there's literally thousands and thousands of data points that what I'm going to tell you next is based on. So the absolute highest risk of infection, the mechanism by which we think most transmission occurs, is from sustained, and by that I mean several minutes of close contact, and that's in an unprotected way, so without a barrier such as a mask, and that's of contact with an infected person in an enclosed space with poor ventilation. So this is like possibly one of the most important things I'm going to say all day, so I'm going to say it one more time. The highest risk for becoming infected is having sustained close contact in an unprotected way with an infected person in an enclosed airspace with poor ventilation. And some examples of this are being in a crowded car, a bus, an office room, a restaurant, a church. There are many, many different examples of this. A factory where there's basically close contact among people for sustained amounts of time without protective barriers between people. In contrast, there are other ways that transmission has occurred, but the risk is substantially lower, but not zero. So let's make that totally clear. The risk is lower, but not zero. First, brief, close, unprotected contact in an enclosed space can also lead to transmission. There are events of transmission that reflect that possibility. In addition, it's also possible that you can get infected from contacting a recently contaminated surface. However, the risk of that is substantially lower than the pathway I talked about above. Finally, even lower risk in those activities are outdoor activities with space between people and masks. So the absolute safest things that we can do basically are outdoor activities where we still give space between people, and if we can wear protective barriers like masks. So the number one thing if we want to do to be safe is we can minimize our risk by increasing space between people, increasing ventilation by either being outdoors or having ventilation inside of the space that we're in an interior space, and decreasing the duration of contacts among people. And to a much lower extent, but still useful if we want to really minimize our risk, we can reduce touching surfaces between cleanings or touching surfaces that are frequently touched by other people. So I hope I've given you some tools to protect yourself. And we might then ask, okay, that's okay at the individual level, but how can we stop these big spreading events that you've heard about? So I want to talk about this in a tiny bit of detail. So there's a term that we use in epidemiology for these events. We call them super spreading events. And it turns out that these occur in all diseases that have ever been looked at. And it's also true for COVID-19. And the idea here, excuse me, not the idea, the evidence here suggests an amazing thing. A few cases cause most of infection. And in fact, for all the diseases that have been carefully studied for this, the majority, meaning greater than 50% of cases, infect no one. So that's an amazing, amazing fact, but that's what the data suggests. So I've tried to give you one example to make this clear. I've shown a picture in the right-hand side of the slide. And the picture here, each circle is a person. And those circles, those people that went on to infect other people are shown in pink or red, whereas those circles that did not go on to infect other people were cases or infections, but did not go on to infect anyone else. Those ones are shown in blue. And if you simply count the blue and pink circles here, there are 57 total circles. 41 of those circles never went on to infect a single person. They were dead-end transmission events, whereas 16 of them do go on to infect people, and 2 of those infected 10 people each. And so this reflects what you've heard about in the news, I'm sure, that there are events that occur, and I've just listed a few examples here, that lead to large spreading events between a number of people. And it's obviously very important for us to try to understand what are the things that are contributing to that. So super spreading events are the combination of multiple things. They reflect both variation in individual characteristics among people, and that includes both how infectious a person is, how much virus they're basically exuding when they breathe or talk or sing or things like that. Also, the susceptibility of the people around them to infection, and also the person's average contact rate. So those are characteristics at the individual person level. In addition, there's now good evidence that what the people are doing can matter quite a bit. And there's several things that have been shown to be increased transmission as well. And those are activities like singing, talking, yelling, and exercising or dancing. Those things also all increase transmission, but I will point out that we don't need to be doing those things to get transmission. Just breathing in a confined, closed space with someone, closely with unprotected, with no barrier between people, can also lead to transmission. But these things greatly increase transmission. Finally, the setting itself, which is independent of the person, can also play a very, very large role in super spreading events. So settings that are really important are crowded enclosed spaces, as I've mentioned a minute ago. In addition, it appears that, there's evidence supporting the importance of low temperatures and humidities in increasing viral survival outside the host. And there are some settings that have conditions like this that are permanent. And these are places like prisons, worker dormitories, meatpacking plants, hospitals, churches, schools, and elderly care facilities. And there are other examples of this that are more fleeting. So think about weddings, choir practices, and parties. So super spreading events are often the convergence of multiple of these things I've listed, and sometimes all three, where we basically get a person that's very infectious, who's doing an activity that leads to the basically lots of virus coming out of that person, either via one of the activities I've shown here or via sneezing or coughing, and especially in a setting that's a crowded enclosed space and may also be contributed to by additional characteristics. So we can say, okay, if these things are so important, these super spreading events are so important, why can't we control transmission of SARS coronavirus 2 by simply asking sick people to stay at home? And I will note, which was a surprise to many of us that work on this disease, that this was CDC and the WHO's primary strategy, or at least one of their main guidelines for many months, was to ask people that were sick to stay home, which is definitely useful. Let's be totally clear that if you are sick, you should definitely stay home. But it turns out this was not going to be sufficient. I don't know why it took them so long to change the recommendations, but I want to note that that actually was a thing. And if you also realize that that was a change in strategy, you're not alone. So the reason that basically requiring sick people to stay home is not sufficient, but it's still very important and useful in reducing transmission, is what I've shown on this relatively busy slide. So the data on this slide here comes from studies of contact tracing and what I'll call infector-infectee pairs, which are basically people that are infected and give the virus to someone else. And the data on the bottom part of the graph is from hospital records on the timing of symptoms. And the crucial detail here is that if we look at when patients first become infected, which basically is this vertical black bar here around minus day 5.5, that's when people first become infected. About 2 to 3 days later, on average, they first become infectious. That's what the data suggests. And then a couple days after that, they show their first symptoms. And the first symptoms that people normally have are cough and fever. And those normally occur on the first day of getting any symptoms at all. In contrast, people often feel a little bit okay. They think they might have a cold. Maybe they just feel a little bit under the weather. They don't feel so bad, so they might still go about their daily activities and may contact other people. But it's usually when they have difficulty breathing and other severe symptoms that they start to seek hospital or health care. And that tends to occur on average on day 6 after they first started developing symptoms. But that's actually close to almost 12 days since they actually first became infected. The problem with asking people that feel sick, and especially feel really sick, to stay home is that these people, by the time they reach this stage of having severe symptoms like difficulty breathing, they've actually already done much of their transmission. So the y-axis of this graph is the relative infectiousness of people, and the x-axis is the number of days since they first had any symptoms at all. And so what I want to make clear again is that there are very strong data now that show that people are infectious before they are sick. So that's basically the black line rising and being above 0 and actually peaking before the first day of symptom onset. And then our infectiousness falls afterwards. And it appears we are infectious for some time after we become sick. But in fact, our peak infectiousness is around the time of symptom onset and possibly a little bit before, which means that if we basically just use the strategy of asking sick people to stay home, we will not be sufficient in stopping transmission because of all the transmission events that will occur basically in this time here before symptom onset. Okay, so that's a great challenge. So then we might ask, how are we going to get out of this? And obviously a vaccine is one possibility. And we might ask, when will we have a vaccine? The answer that I think most of you have heard probably hundreds of times now is 12 to 18 months. But we do hear a few optimistic ideas here and there that it might be shorter. And in fact, just on the NPR this morning, Anthony Fauci said maybe it would be as little as 8 months. So that's possible, but that's an optimistic outlook. But we still want to ask, why so long? Why can't we get a vaccine sooner? And the answer is that we eventually will want to give the vaccine to everyone on Earth, which is 7.6 billion people. And if we do that, we want it to be safe and effective and not worse than the disease itself. So that goal, this idea that we're going to give this vaccine when we develop it to this enormous number of people, is that it's really, really important for it to be safe and not cause worse events in people than getting sick than the disease itself might cause. So I want to just briefly explain why it takes so long to develop a vaccine and why we have 3 trials to do so and what each trial is composed of, so that you can use that to interpret information that you will be receiving over the next year or so about progress in vaccine development. So when we develop a vaccine, we have 3 phases. The first phase is a small scale study, usually with tens of people, so maybe 20 people, maybe 50 people. They're always very healthy people, and these studies are almost always done in healthcare settings, so with doctors kind of on the standby, ready to help if there's any issues at all. And they usually use different doses of the vaccine and sometimes different numbers of times that you get vaccinated. The most important outcome in these studies is not whether the vaccine is protective in protecting someone against infection. It's literally just trying to determine, is the vaccine itself safe? Will it cause serious or very severe adverse events in a substantial number of people, in a substantial fraction, right? So there's only often 20 or 30 or 50 people in these trials. So if it's relatively rare, we're not going to pick it up with this first small scale study, but we will pick up if the vaccine itself is very dangerous and causes severe events in large fractions of people. There's a secondary outcome, but it's not the main outcome of these phase 1 studies, which is to ask, does the vaccine produce an immune response? And if so, how strong is that immune response? There's a few ways of measuring that. The two that are used the most often are whether a person produces binding antibodies or neutralizing antibodies. And there are basically two different ways of measuring their antibodies. The antibodies themselves are the same, it's just a different way of measuring them. Neither of them demonstrate full actual efficacy or protection from infection, but they're both useful, and neutralizing antibodies are more correlated with protection than just binding antibodies. The duration of phase 1 clinical trials, it usually are on the order of months, sometimes up to 6 months. And the idea there is that, of course, if injecting the vaccine into someone causes a bad outcome, it may be visible or may actually occur after just a week. And that would be great if all the bad things happen quickly. But sometimes there are things that happen that take longer to occur. And if we don't wait for a little while, we'll have missed those. So that's why phase 1 clinical trials often last several months. If a vaccine candidate does well in a phase 1 trial, it moves to a phase 2 trial. And phase 2 trials are of medium scale. They generally include hundreds to low numbers of thousands of people. They obviously use the information from the phase 1 trial in terms of dosages and how many times to vaccinate people. The primary outcomes of phase 2 trials are, again, safety, but with a larger sample size to pick up rarer events, and also to understand how immunity is being developed by people that have been vaccinated. A secondary outcome that can sometimes be observed in phase 2 clinical trials is how actually effective they are in protecting those people, but that's not the primary outcome. Again, the duration of the phase 2 clinical trials are generally, again, months, often 6 months, and that's again to see delayed these adverse events that the vaccine might cause if they exist. And because we have hundreds or maybe low numbers of thousands of people, we can pick up rarer events. Finally, phase 3 clinical trials are large-scale trials, usually with thousands of people or sometimes tens of thousands of people, or possibly even bigger. And here, finally, the primary outcome is whether or not the vaccine actually works. Does it actually protect people from infection and disease? In addition, of course, we're still trying to monitor, are there these adverse events, side effects basically of the vaccine that are bad? And because we have a larger sample size now, we can pick up much rarer events. So things that are occurring on the scale of, say, 1 per hundreds or 1 per thousand. The duration of phase 3 clinical trials are usually also months and sometimes even longer. And that's because we actually need to wait long enough to observe a number of events, meaning infections or illnesses, in our control and vaccinated groups to demonstrate whether the vaccine works or not. And that really only can be done in a place where there's active transmission in the community. So we can't actually do a vaccine study if there's no transmission occurring. So that presents a substantial challenge in places where they've had transmission and then it's been stopped through control efforts. I will say that this phase 3 clinical trial can be shortened significantly by what I'll call a challenge study or an experimental infection, where people actually volunteer to be vaccinated, and then after being vaccinated, volunteer to be challenged with the virus itself. So that's not normally done, but it has been done before with more wild diseases, and it is definitely being considered by major funding bodies for this disease, because it would greatly shorten and be much more quickly effective in determining the efficacy of a vaccine. Finally, there is a such thing as a phase 4 clinical trial, but that actually just refers to the stage in which the vaccine is being deployed in a wide scale at the population level, and it just means that we continue to monitor effects of severe and adverse outcomes if they occur at lower frequencies. It turns out that all 3 of these phases of clinical trials can show whether vaccination has an immediate protective effect, especially phase 3 clinical trials, but within the first 6 months, we won't know how long immunity lasts, and that's going to be a recurring issue that I'm going to discuss a little bit later. Okay, so I'm sure you all have heard of many vaccines that are in development for COVID-19. Last time I checked, which was day before yesterday, there were over 100 in development, but that doesn't actually mean very much. We actually need vaccines to get much further along these stages really to be useful in the near-term future. Thankfully, there are at least 8 different vaccines in clinical trials. All of the ones that I have read about are in stage 1 or stage 2. One that you probably heard the most about because it's been in the news in the past 4 days is a vaccine that's a joint venture between NIH, actually an arm of NIH called NIAID, and Moderna, a company. And that's an mRNA vaccine. And this is still in stage 1, but they're starting stage 2 soon. And I should note that there is the possibility, if stage 1 is it goes relatively well, that you can request permission to start stage 2 while stage 1 is still going on. So that is to say, if you've injected people with the vaccine, let's say 2 months ago, normally you might want to wait 6 months, but if you had no adverse events, you might say, can we start stage 2 now as well? And obviously it's risky, but of course it shortens the overall time to develop a vaccine. If you want to talk about the details of this recent press release on this vaccine, ask me about it in the Q&A. So we can then ask, what are we going to do until we have a vaccine in 12 to 18 months, or maybe it'll magically be shorter than that. But if not, then that's the time horizon we need to be thinking about. And we can also ask, why aren't we doing it already? And so as I see it, there are 3 paths one can do to try to address this pandemic that we're all experiencing. The first strategy is to do nothing, and we know that that strategy will lead to too many infections and deaths and overwhelm the hospital healthcare system. So I tried to present that in the very early part of the talk. I think that's not a strategy we should employ. If people want to talk about that a little bit more, ask me a question about it in the questions and answers at the end. The second strategy, which we are mostly living in right now, is a shelter in place or a lockdown strategy. And I think all of us can appreciate that these are very damaging for society and the economy and cannot be sustained for a very long period of time. Thankfully, there's a third possibility or a third path, which is where we limit transmission. We keep the reproductive number of the pathogen less than 1, the number of cases per case, through active case finding and testing, contact tracing, and isolating infected people, and still employing some moderate social distancing, so not nearly the extent of the lockdowns or shelters in place we have now, but some moderate social distancing. And that includes sequential reopening of tiers of businesses and institutions, and adaptations of businesses to minimize transmission and risk. So we might ask, why aren't we already doing this strategy that I proposed here that especially includes this active case finding? And the answer is because this strategy, testing, contact tracing, and isolation, especially done at the level we need to do it at, requires a relatively low number of active infections to be effective, a high capacity, fast testing capacity, a high and fast contact tracing capacity, and safe isolation space and food and services for people that are infected or being quarantined. So in Santa Cruz County and most of California, and in fact many other places, after an initial rise in cases in March, on this slide here I've shown the number of reported cases from a website for santacruzhealth.org, which basically shows our latest status for COVID-19. If we look at these cases, and if we use these data to estimate the reproductive number for the pathogen, in Santa Cruz County, it decreased from about 2 to about 1 over the last couple months. But unfortunately, it's not that far below 1 despite the lockdown. And that's really important because what it means is if we reopen some businesses and increase contact among people, that's going to increase transmission, and that will make R greater than 1, and cases will grow again. So what that means is that if we're going to open up some businesses, we need to do some additional things to reduce transmission to maintain the reproductive number of the pathogen less than 1. So you might ask, what can we do? So how can we reduce transmission further to maintain the reproductive number of the pathogen less than 1 with more businesses open and more activities among people? So the current strategy in most places of the US has been primarily passive surveillance, where patients present themselves to healthcare providers, and then we do contact tracing on these cases. Because of what I mentioned before, and I think I'll show it again on the next slide, this strategy is not effective in reducing transmission so that the number of cases per case is less than 1. It's simply not effective enough. And this is because the people that are coming to healthcare providers, often with shortness of breath and other severe symptoms, have often done much of their transmission already. In contrast, we need active surveillance, and where we recruit or ask all people with mild cases, just coughs and fevers, to immediately, as soon as they feel sick at all, come get tested, and then we'll trace their possible contacts and see if they've infected anyone else already during their pre-symptomatic period. And if we can do this, we can actually get the reproductive number of the pathogen to be less than 1 and substantially less than 1, so that we have room to open more businesses and still maintain transmission basically below 1. Okay, so I mentioned this before, but I just want to reiterate it again. The idea here is that because people get infected, there's a couple days before they become infectious, but then they're infectious a couple days before they get sick, and then they get sick with mild symptoms, and then get severe symptoms about 6 days later. We really need to get people basically just after their symptom onset, so right around this time here, and then try to prevent all the transmission that occurs after that. If we wait until here, all this area underneath this curve is all transmission that has occurred before people have severe symptoms or symptoms like difficulty breathing. So the challenge is that waiting for people to come to a healthcare system will basically miss most of the transmission that's actually occurring. And so I've done a little diagram to try to explain this, because this is fundamentally one of the most important parts of this strategy. It is that if there is a case that's here, infection occurs on this day, there's a little delay before they become infectious. That's shown by this big kind of red cone. They have their first symptoms after a few days of becoming infectious. And during that time, there can be transmission to a second case down here. Then it turns out the data suggests that their infectiousness actually declines over time. And unfortunately, they don't usually seek healthcare until much later in their infection, when they've actually already done most of their transmitting. And so if we trace their contacts around this time, unfortunately, they've already gone on to infect this person. And in fact, it's been so long, this secondary case, in fact, has already gone on to infect people as well, because we're basically late in their infectious period as well. In contrast, we need to isolate, contact trace their cases somewhere in this period, and that can occur if we find people just after symptom onset, which is basically occurring here. We can then trace their contacts and find these people in this phase here, and that's what we need to aim for. So to meaningfully reduce transmission requires testing, isolating, and contact tracing people immediately after the onset of mild symptoms, not waiting for difficulty breathing. At that point, it's too late. So it turns out the requirements for actually using this strategy are that we first need high capacity testing with rapid results. The relatively large number of people with mild symptoms, it's much larger than those with severe symptoms, requires high capacity testing. And of course, some people have symptoms that are not infected with COVID-19, and we have to test them as well. We need the test results to be returned very quickly, otherwise people can go on to spread the virus during that time. And so we need to basically test them quickly and then immediately trace their contacts. Unfortunately, there are a large number of close contacts that may need to be isolated and tested, especially after we reopen some businesses. That number has been estimated to be between 20 and 50 if there's no social distancing happening. And that means that's going to require a bunch of testing. So we need high capacity testing with fast turnaround time for the results. Second, we need high capacity contact tracing and safe quarantine facilities with food and provisioning for the people that are basically being quarantined. So as I mentioned a minute ago, each infected person may have as many as 20 to 60 contacts from their potential infectious period if we fully release all the social distancing that's in place now. And that means that each of those contacts will need to be contacted and quarantined until they are shown to be uninfected. If there's even a small number of infections in a community, so in a place like Santa Cruz County, if there's between, let's say, 10 and 30 people that are infected, that would require contacting hundreds of people, testing all of them, and providing them with safe space to isolate. So this last bullet is really key. We need to basically offer a safe place for people to isolate. And if they live in a house with other people, we have to find a way to give them space so that they don't infect their housemates. While they're isolating, we also need to give them food and other things that they need. Otherwise, they'll need to go to the grocery store where they might infect other people. There's very good news on this front, which is that in Santa Cruz County and in many other places, but not everywhere, many of these things have been developed, and we should be able to switch from the shelter in place that we're experiencing now to this much more effective strategy soon. So first, in terms of high capacity testing with fast results, a number of hospitals and healthcare providers in Santa Cruz and neighboring counties now have their own capacity and machines to do testing, which is fantastic. The state has also provided a team that does testing. And finally, there's a group of us at UC Santa Cruz, whose names I've listed here, that have also developed high capacity testing, where the turnaround time for results should be within 24 hours. In addition, as we're approaching summer, there will be fewer other non-COVID-19 respiratory illnesses, and that should reduce the amount of tests we need to do, because less people will have coughs and fevers from, let's say, the common cold or the flu. Second, we needed a low number of active infections and high capacity contact tracing required. And so thankfully, the shelter in place we've been experiencing for the last couple months will have reduced the number of active infections substantially compared to what it was before. In addition, there are a team of contact tracers that are being trained right now for Santa Cruz County and the rest of the state, and actually nationally as well. And there's been development for digital contact tracing, which there are some issues associated with that you can ask me about in the Q&A. Finally, we need safe isolation space and food and services for people that are being isolated, and that's also being developed. I want to point out that the county, and especially the county health department, especially led by a team that involves a woman named Margaret Lapice, as well as a large group of staff on the county health department, and a large effort by the Community Foundation of Santa Cruz County, led by Susan True, are making major contributions to all of these things. Okay, so that's great, and we have many of these things in place, but there's really one super, super, super big thing we still need to make this work. And that is that as soon as all these systems are in place, we're gonna need to do outreach to get everyone that's in the community that has mild symptoms to come get tested immediately. And we have to do this in a way that doesn't make people feel, basically that makes people feel safe and want to do this and be part of this overall effort. And that means we need care in reaching out to people that have understandable distrust in government and, for example, undocumented people. So in addition to this overall strategy, we also need to each do our part to voluntarily limit activities that are basically going to reduce transmission and especially avoid super spreading events. And so it's a great thing, but California is not a police state. There's no way that the police can basically enforce us all to be safe. We have to take those choices to do that ourselves. And so we have to basically choose voluntarily to not engage in large gatherings where we're going to be close to each other for sustained amounts of time, especially in enclosed spaces. And we each personally need to minimize our own risky behavior, which means try to avoid sustained close contacts in enclosed air spaces with non-household members and do small things we can like wear masks and wash our hands. So these are the things that I want to try to outline that we know, and I want to try to outline a few things at the last part of the talk of things that we don't know and the consequences of not knowing those things. So here's the first of the big unknowns. We actually don't know how much virus you need to be exposed to become infected. And that's very challenging because it actually makes this quite difficult for us to interpret studies where we study things like the distance droplets travel when people breathe or speak or sing. And so, for example, you may have heard press articles on a paper that just came out that said, if there's wind, then droplets can travel up to 6 meters or almost 20 feet from a person. And therefore, if you're 6 meters down from someone, you better watch out. And it turns out that we can't safely interpret that data because we don't know how many of those droplets you need to be infected. So is it possible you could be infected by someone if you were 20 feet downwind of them and they breathed or coughed or sneezed? The answer is yes, it's possible, but the likelihood of that we really don't know. The evidence so far suggests it's actually quite low, but we can't properly quantify that until we know what the infectious dose of this virus is. So we have a lot of data that suggests that transmission is consistent with the highest risk being direct, close, sustained contact, but there is a little bit of evidence as well for dispersed aerosol transmission in some of the super spreading events. So it would really be quite helpful if we could get some data on this. Similarly, because we don't know the infectious dose or the amount of virus that's required to cause infection, it makes it hard for us to determine what's the extent of risk from touching a contaminated surface. So there was a paper a few months ago that many of you may have seen that suggested that the virus could survive for between 24 and 72 hours on surfaces, but just because the virus can survive there doesn't mean there's enough virus there to infect us, and we need to know that infectious dose. Just in the last couple days, CDC has updated its website to say that this virus does not spread easily on surfaces, which is not to say it can't happen, but it doesn't happen very often. The evidence for that switch in guidance is not super clear, and it appears to be based on the absence of evidence, but let me be clear that the absence of evidence is not evidence of the absence. So I think this is one of our key unknowns that will help us to understand things. I will say that we do have data that suggests we can help interpret the riskiness of some activities just simply based on the fact that we haven't identified them as major transmission pathways. So for example, contaminated surfaces does not appear to be the source of many transmission events, and that's why CDC has listed this in its website, and that's consistent with other data that's available. So a second large unknown is what effect will opening up each sector of society, each tier of businesses have on transmission, especially if some other measures, including masks and other social distancing activities, are in place. And unfortunately, this is a big unknown, and that's because we've never done this before, right? So we've never had societies do full lockdowns at the country scale and then try to sequentially open some subsets of businesses. There are new data showing up all the time, and in fact, just this morning, there's a new paper out on what the effect of opening some segments of businesses have on transmission. The reason, because we don't know this, the strategy for trying to return to a more normal life is to take a staged approach where we open businesses in kind of tiers. And if we can do that at the same time that we ramp up this testing, contact tracing, and isolation strategy I talked about before, is our best approach. The goal here is to reduce transmission as much as possible to avoid an outbreak and sustain transmission. Thankfully, we don't have to completely eliminate all risk. We don't have to get the reproductive number to 0. We just need to keep it below 1 to keep infections limited. Unfortunately, because we don't know what the effect will be of, say, opening up a subset of businesses, it's possible that we'll see sustained transmission and we might have a large enough outbreak that will require some form of reimposed lockdowns, and we're trying to avoid those as much as we can. A third big unknown, and this is a huge one, is if you become infected and you survive, does that confer immunity and how long does it last? So the challenge is that the first sizable number of infections that occurred for this virus at all were in Wuhan, China in January, about 4 months ago. And unfortunately, or not, excuse me, not unfortunately, so since then, thankfully, due to amazing control efforts, there's been relatively little transmission in those places now. But that means that unfortunately, it's quite challenging to assess whether the people that live in Wuhan, especially that have been exposed, been infected and recovered, now are immune. So without something like a challenge study I mentioned earlier, which is obviously very, very risky, it's difficult to know whether recovered patients are immune and how long that immunity lasts. I will tell you that there are data from other coronaviruses. There are 4 different viruses, types of viruses that cause the common cold, and there have been 2 more serious coronaviruses that have infected people in the past. SARS coronavirus 1 in 2003 around that time, and MERS. All these viruses suggest that there is immunity, and we call this immunity sterilizing immunity, where there's the person that's immune does not get infected and actually does not get sick at all, and that's the best kind of immunity. And data from these other viruses suggest that this does happen, but unfortunately, for these other viruses, immunity appears to wane after a period of 1 to 3 years, although there's some recent data that suggests that it might last even a little bit longer for a subset of patients for one of these viruses. There is data for this virus, for SARS coronavirus 2, and that data suggests that people do mount antibodies after infection, and in fact, most people do, which is very good, and that these antibodies, I told you before, we can measure them in 2 ways. One is binding and one is neutralizing, and neutralizing is better. And in fact, most people mount antibodies that are in fact neutralizing, so that's great. But although it's promising, it does not guarantee that this kind of antibodies confer what we'll call sterilizing immunity, meaning that the people can't get infected and don't get sick. In addition, these data we have so far do not indicate duration, simply because people have not been infected for that long. We can't measure that yet. So the consequence of this is that if there is immunity for this virus, but it doesn't last that long, let's say it wanes after 1 year or 2 years or 3 years, we might need to get vaccinated either every year or at some interval, like the flu. And of course, because this is a much more deadly disease, it'll be much more important for us all to get vaccinated. Okay, the fourth big unknown is the role of different segments of the population in transmission, and specifically the role of children. So one of the key things that many places in the world, one of the key measures that people did to limit transmission was to close schools, which opens the obvious question: if we reopen schools, are we going to get a lot of transmission and possibly super spreading events? The answer is that's only going to happen if children are both susceptible and infectious. We know, of course, that the contact rates in schools are very high. There are a number of papers on this, and some of them, although not all, suggest that children are equally susceptible to infection, and others suggest that children actually have a lower susceptibility to infection. Unfortunately, most of these studies were done when schools were closed, so we really don't understand yet what the impact of opening schools is going to be on transmission. Although again, just in the past week, there are some data providing an initial clue to this question. There has been a study that suggests that children have similar viral loads as adults, which helps address whether they're infectious or not, but that's a small scale study and we need more data on that. In addition, there's been a bunch of studies looking at contact tracing, and many of these studies show rarely show that children are the person that's doing the infecting. So they're rarely shown to be the infector. Unfortunately, again, we don't have very many data points. We don't have very many studies when schools are actually open and when contact rates are the highest. And because children generally show lower symptoms than older people, there's a little bit of a bias in how we assign in a given family, if there's multiple infections, who gave it to who. We often use who got sick first. And of course, if children don't get sick at all or get sick later, we'll get a bias in that analysis. Okay, so those are the big unknowns that I wanted to talk about. And I just want to wrap up by trying to give you guys a couple tools to help safely interpret new information as it comes out. So there's a bunch of questions that keep coming up again and again and again with new studies and new popular press articles, and I want you guys to have the tools to interpret those. So the first is how long does the virus survive both inside and outside the host, and can people that have been previously infected get reinfected or become infectious again? This question has come up, both of these have come up many times, and the crucial question that you should ask if you see a report on this is, did the study measure actual virus, live virus, or RNA? It turns out that almost all studies that are done measure just viral RNA and not live virus, and those are not the same thing. So for example, there are 3 headlines that you may have heard. Coronavirus was detected in the air over Wuhan, China. Coronavirus was detected on a cruise ship 17 days after all the passengers left. And coronavirus was detected in patients long after recovery. All 3 of these headlines were based on studies where they looked simply for RNA of the virus and not for live virus. And later, these were all shown to be basically just viral fragments or pieces of dead virus. And that means that the conclusions that one might otherwise draw if it had been live virus are not correct. So as you go forward and as you see press reports that appear to suggest the virus being extremely widespread or people becoming infected again or things like that, ask whether or not the detection was by a live virus itself or just viral RNA. Another recurring question is what fraction of infections are asymptomatic? You'll see many press reports that will say, oh, this group of Navy sailors were screened and only 50% of them or 60% of them had no symptoms. And you need to ask then, did the study follow up on all these patients to see whether they got infected, whether they got sick later, or was that data coming just from the initial tests? And all the studies that I've seen, and it's a large number now, suggest that the fraction of people that are asymptomatic is often very low, usually below 20%. If we see a larger number, it's usually because people have done a simple first screening of people for virus and then not followed up with those people to see if they become sick later. And as we probably all know, it can take as long as 2 weeks for people to first show symptoms. So if we don't follow up for at least a couple weeks, we can miss people that are infected but not symptomatic yet, but become symptomatic later. Okay, so the second set of tools is you're going to see lots of studies still on how is the virus spread, and you should ask, did the study measure viral transmission directly, or is it measuring it indirectly? So for example, there's been a number of studies just in the past couple of weeks using fancy technology like lasers to look at water droplets expelled when people talk or sing or yell. There's lots of studies on viral survival on surfaces, especially looking at the effects of temperature and humidity on viral survival. And we want to ask, okay, did they actually measure transmission directly, or are they just measuring an indirect form of it? And if so, be careful about making conclusions based on that. And we can also ask, if this mechanism of transmission happened frequently, meaning it was really important, what patterns of infection would we see? So this will help us to separate things that could happen from things that happen frequently, and that's really important. So let me reiterate again, there's very strong existing data that suggests that high-risk activities are face-to-face interactions without barriers in crowded, closed environments with talking, yelling, singing, or heavy exercising and breathing. Much lower risk, but not zero, are sharing an airspace with people without face-to-face interactions. There are some evidence, there are spreading events that have occurred that way, but they're much lower frequency. And that we do not have any evidence that small droplets can persist in the air for 8 minutes and are highly infectious. If that was the case, then there'd be much, much, much higher transmission than we have seen. So that's evidence that supports this idea that we need to think carefully about whether a study that suggests something could happen is actually happening frequently in nature. And then finally, you're going to see many, many studies that try to extend results based on a small segment of the population to a much larger population. And so some of the things that have come up is, what are the fraction of a population that's already been infected and have immunity, and what does that imply about the deadliness of the disease? We should ask, in that study, what is that study group population? And is it a random sample of the larger population, or a representative sample, or is it a very skewed small segment of that population? And if so, we can't extend those results to the larger population. This is going to apply both to that question and also to the reports of vaccine or drug treatment efficacy. We need to ask, what was the group that was treated or vaccinated? Is it the target population in terms of age or pre-existing conditions? And if not, then we can still be optimistic, but that optimism needs to be tempered. So I'm going to close by saying that we need to think about COVID-19 as not just something that's happening to us in the next month or two, and then everything is going to go back to normal next week or even next month. There's a long road ahead of us. And crucially, our actions are going to determine what happens over that long road, and we can choose which path to take. And so with that, I'll take questions. So I'm going to look through the questions briefly that you guys have submitted and try to pick some that I think will be of broad interest. Okay, so I think let's start with a bunch of great questions here. Yeah, so I'm gonna hit a few of the ones that I can answer quickly, and then I'm gonna take a little bit of time to answer ones that will require some more discussion. So there's a question here that asks, what do the data suggest about antibodies for the people that have survived it? What factors influence the antibody response that we see, and how effective that might be? The answer is that there was a little bit of concern early on that some people mounted a strong immune response and some did not. Thankfully, in follow-up studies of those people, many of the people that initially did not mount an immune response, a strong immune response, did later. And so there's a recent paper that suggests that the great majority of people that become exposed, whether or not they have severe or mild symptoms, will produce relatively robust, what we'll call neutralizing antibodies. But again, let me be very clear that we do not have sufficient data to say yet whether those antibodies that we do see that are neutralizing will confer protection or for how long. Another quick question here that's a good one, which is, how often do vaccines in general have negative outcomes? And the answer is that every vaccine that I know of has a certain number of adverse events, basically side effects that we don't want. And the 3-stage clinical trials are set up to try to basically prevent any vaccine that's not safe from being used in a widespread kind of large-scale way. But all of them have some side effects, and generally all the ones that we use in general populations have very rare side effects, because that's the whole goal of that 3-phase clinical trial. So, so the ones that we have tested so far for COVID-19, we simply don't have remotely enough data to know what fraction of people will have adverse events yet. Let's see. So, quick other question, can vaccine development be accelerated? The answer is yes, and the 2 main ways that people are doing that is by overlapping the clinical trials, which increases the risk, obviously, of seeing additional adverse events that we would not have let a vaccine move to further stages, but it speeds things up. And the second major way, besides overlapping the clinical trials, is by using challenge studies for the third phase 3, where we're looking at actual efficacy or protection. And that's obviously very risky, but it can greatly reduce the amount of time. So those are great questions. Yeah, we have a couple questions about testing. And so the accuracy of current tests. And so for the virus itself, there's actually a number of really nice recent syntheses on testing and how accurate they are, especially by the common nose swab, the nasopharyngeal swab you've probably heard much about. The accuracy of those, let's say it both ways, most of those tests are very, very good in terms of having almost no false positives, because they're basically detecting different parts of the virus itself, and they actually look for multiple parts of it. And so when combining those things together, we almost never have false positives. Unfortunately, a substantial fraction of people, when given a single test, will test negative even if they are infected, and that probability or fraction is lowest right around symptom onset and increases forward in time. So if you basically wait until you have severe symptoms, then the chance that you actually test negative, even though you're actually infected, increases slightly. In addition to that, what we actually have no data on yet, which is very frustrating to me, is we don't know yet, before you're sick at all, what's the probability if you are infected that you will test positive. And we need to know that to determine whether or not we could safely identify someone as not infected before, say, waiting 14 days. Let's see. Yeah, so a question that I tried to address, but apparently probably didn't do a good enough job. So there's many reports of people that are infected and that we think recover and then test positive again. And the answer is that all of those studies have now been very clearly shown to be people that are infected. They're sick and you can test them positive for the virus, but then when they get tested again, let's say a month or 2 months later, and we again test them positive, those are for viral fragments, and that is not for live virus. And there is no evidence yet of any of those people going on to infect their housemates or people that they are near. So that does not indicate reinfection or even the virus coming back up again. It simply indicates that when the virus infected your tissues, it takes a long time and you're shedding viral fragments, pieces of dead virus for a long time that show that they come up positive in a test, but do not indicate that you're actually still infectious. So great question. Let's see, I guess I should do it. Yeah, let's go ahead and do the mask question. So, I put a bunch of slides in the back to try to answer some of these questions, and so I wanted to try to address a few of those. So Let me do the masks one. So, so we've gotten such mixed messages about masks that I wanted to try to clarify that. And so we might ask, why has there been so much flip-flopping on masks, both by the CDC and the WHO? And here's the answer to that. So if you look at, there's a huge amount of science on masks, and you can ask, do they protect the wearer, the person who's wearing the mask? And the answer is partly, but not nearly as effective as we would like. And they are much more effective when we wear them properly and take good care taking them off. So basically, if you take them off in a bad way where you touch part of the mask that has virus on it with your hands and then rub that into your eyes or nose or mouth, you can get infected. So the masks are, I would say, weakly to moderately protective for the wearer, depending on the type of mask and how well they're worn and taken off. In contrast, there's quite good data to show that the masks can be quite effective in protecting the wearer's friends, which is to say they can reduce transmission from a person that's wearing the mask, excuse me, even if they don't necessarily reduce infection of the person wearing the mask by that much. So if that's the case, then we might say that it's quite important to wear a mask, not so much to protect yourself, but to protect the people around you. And that's definitely true. So we then can ask, why didn't the CDC and the WHO say not to bother with masks early on in transmission for the first 2 months? And the main reason for that was that, as I'm sure you're all aware, there was a shortage of masks, both surgical masks as well as these kind of specialized N95 masks. And public health officials were very worried that if they recommended that people wear masks, they would all be bought up by people, and there wouldn't be enough for healthcare workers and nurses and doctors that need to be very close to infected patients. In addition, CDC and other public health agencies were worried that people that wore masks would think that they were safe and protected and might go out and do things that were otherwise risky, and that would not be a good idea at all, especially if people weren't wearing their masks properly. So the combination of those things meant that initially the CDC thought that it was actually worse to encourage mask use than to discourage it, but eventually realized that because of the second bullet here, that masks protect wearers' friends, it was actually useful to encourage mask wearing. And that's where now most public health agencies in the world now support that idea. So that's the mask part. Let me see if I can get a few more questions here. So yeah, so there's 5 or 6 questions here, all about trying to ask what can we do to reduce transmission. And I'll come back to what I tried to say before clearly, but I'll reiterate it again. We know what the highest risk transmission pathways are, and that's being in close, sustained contact with people in an unprotected way, meaning no mask, things like that, in an enclosed space with poor ventilation. So it just means that to reduce transmission, we just need to reverse each of those things. So we basically need to avoid being in close, unprotected contact with people in enclosed spaces for large amounts of time without having masks and things like that around us. So in all settings, that tool can be used, and that's our most effective thing that we can do. I want to say briefly that you've probably heard that a safe distance is 6 feet, and you might ask and wonder what's special about 6 feet, and the answer is nothing, except that we do know that droplets, when you breathe or talk or sing or things like that, most of them fall to the ground within a relatively short distance on the order of just a few feet, and therefore if you are 6 feet or more from a person, the probability that any of those droplets will reach you and you'll breathe them in and get infected are lower. But 6 feet is not magical. 3 feet is better than 1 foot, and 5 feet is better than 3 feet. So basically, the more distance you can give between people, the lower the probability of transmission occurring. Similarly, simply passing by someone very quickly that might be breathing, if you say pass within 6 inches or even a foot of someone, although that's certainly much riskier than being 6 feet away, if you do so for a short amount of time, the risk of that is very, very low. However, as the amount of time that you spend within a close distance of someone without masks increases, your probability of transmission also increases. So basically, anything we can do to reduce the amount of time that people are close by each other without masks for a sustained amount of time in an enclosed airspace is going to be risky. And the things we can do to reduce that are to increase ventilation, move activities outside, give people more space, and wear masks. So all those things can substantially reduce transmission. Let's see if I can hit a couple more questions here before the time. Okay, answering that one. Great. So here's a great question that asks about even if Santa Cruz or other places takes a very, very effective local strategy, how effective is that going to be if there are people moving, visitors coming to that place? And so many, many places, of course, I think want to be safe themselves, but people obviously also want to come there and travel to there. And how does that work? And so the answer is that immigration, or the movement of people, especially if a substantial fraction of those people are infected, presents a major challenge, and that challenge should not be discounted. So let me just answer that question with an example. I think one of the places that people would argue has had the most success in implementing exactly the strategy I outlined before, this testing, contact tracing, isolation strategy in a very active case-finding kind of way, is Hong Kong, and Singapore as well. And so that's been great, but as the number of people that are coming, basically visitors or immigrants coming into those places, if that number is high, and if some of those people are infected, then that presents a real challenge for that, that overall strategy. And let me highlight again that that strategy is most effective when there are a relatively small number of active infections. So as the number of active infections grows, basically things just get out of control, and there's too many infections with too many contacts for that strategy to be really effective in a timely manner to reduce transmission. And what that means is that if there's a large number of visitors or immigrants, or whatever word you want to use to describe that kind of spatial scale of movement, that are infected, that can present a real challenge. So the number one thing that can be done is to make the interactions between those people that are infected and those people that are uninfected low risk, is to reduce those high risk activities that I talked about as much as I could. So specifically for a place like Santa Cruz County or any other place that's relatively effective in keeping transmission low within their county, if there are visitors coming to that place, the number one priority should be to make those interactions between the local people who are maybe primarily uninfected, if they've been successful in reducing transmission, and some of the visitors that maybe some of those are infected. We need to make those interactions safe. And the way we make those interactions safe is by, as I said before, and I'll say one more time, limiting the number of sustained close interactions that are unprotected between those people in confined airspaces with poor ventilation. So those are great questions. So there's several questions here about large gatherings of people, and especially say starting classes again at UCSC or at other campuses, and what are some of the challenges related to that, especially having to do with super spreading events. And those are very real and big challenges. What should I say? I will say that there are many, many people. I'm on a couple task forces trying to address whether it's possible to do any of those things safely. And I will say for now that those types of activities, having classes on campus at universities, and all the things that are similar to that, having church services with 100 people in a room, all these kind of things all have obviously big similarities, are safest if basically the fraction of people in a population that are infected is low. So if we can do other things to keep transmission low, that will greatly reduce transmission in these high kind of crowded settings. But there are still going to be ongoing challenges with that, and there's no easy way out. So I think there might be one or two more questions that I'll use to try to address that. But the short answer is that there are no easy ways to address that. There are some ways to minimize the risk of that, but there's no ways to make that not a risky proposition. Yeah, so there's a few questions here that I think I can quickly answer about whether or not this virus could have been around in the US or other places, let's say 6 months ago. And the answer is that there's pretty strong evidence that that's not the case, and that evidence comes from a number of things. One is a widespread screening of samples from people that went to the hospital or went to their doctor from before January. And in the US, none of those have turned up positive. Some of the listeners today may know that there was actually a case detected from one of these previous samples of a person in France much earlier than they otherwise thought. This was in late December, but it was a single case. And so I think given what we now know about transmission that was occurring in Asia in November, late November and early December, I think it's not surprising that there may have been some cases some infections, infected people that basically traveled from Asia to other places. And so there may have been 1 or 2 people in one of these places that might, later testing might turn these people up, but there's no evidence at all that there was widespread transmission of any kind in, let's say, the US prior to January or February. And that's despite quite a bit of looking. And in addition to that, there have been quite a few studies using the relationships among the RNA and the virus itself to examine how long the virus has been around in a given place. And those data also do not support widespread transmission before January or February. Let's see. So there's a few questions about, oh yeah, I probably should have anticipated this ahead of time. Well, anyway, that's okay. So there's a number of questions about mutation of the virus and what effect that might have on our response, on vaccines, things like that. That's a great question. So this virus is an RNA virus, and so it mutates relatively rapidly compared to other organisms. And there's very widespread evidence of the virus mutating all the time. But despite that, there is no evidence so far that that the virus has changed in measurable ways that we are confident about. So there was a couple high-profile papers that were not published yet, but posted to preprint servers, we call them preprints, that received very substantial press coverage, suggesting that there might be a mutation or two causing maybe a strain of the virus to be replicated to replicate to higher levels within people and to be spread more efficiently among people. The data from that study and other studies like it are correlative suggestions that that mutations that we have seen in the virus may have caused some differences in the virus, actual functional differences, say differences in either, transmissibility is a possibility, but all of those data can also be explained by other mechanisms, especially having to do with when mutations occur and then when those viruses with those mutations basically are introduced into populations and due to kind of random drift and founder effect processes. So most of the virologists that study this virus and that are looking very carefully at all these things would all agree that there's been a substantial amount of mutation in the virus, but that the evidence for mutations leading to functional changes in the virus that affects either its infectiousness or deadliness, there is not strong evidence for that yet. There are some relatively weak correlative evidence that may have occurred, but certainly not convincing yet. And there is certainly no evidence yet that the virus is mutated in a way that would affect our immunity to it or whether a vaccine would be effective. That's not to say that that cannot happen. That's to say that we do not yet have evidence for that. So hopefully that addresses some of those questions. See if I can get to, oh yeah, so I thought there was going to be a question about this. So let me actually go ahead and address that with this slide. Yeah, so there's a question about, is there evidence for seasonality in transmission and will summer save us? And so many people, including the president, were hoping that summer would come along, the virus would just disappear and our lives would go back to normal and be fantastic. And so the evidence for this is unfortunately not that helpful. So there is a number of papers that have looked at the effects of temperature and humidity on the survival of this virus outside the host, and those do indicate some effects on survival. But all the studies that have looked at this, and I know of 3 very prominent ones so far, have all concluded that the effects of temperature and humidity on viral survival outside the host, as well as human changes in behavior that occur seasonally. So in the summertime, in the US, we tend to spend more time outside and less time inside, with some caveats with very hot places where people spend time in air-conditioned areas, suggest that, well, that could moderate transmission a bit. A much more important factor is the fraction of the population that is still susceptible to infection. And unfortunately, everywhere we've looked, that fraction is still too high to limit transmission. Some additional evidence that supports this idea that summer will not basically stop all transmission is that transmission has been occurring and at relatively high rates in many places that are quite warm. So many of you have probably heard of transmission occurring in places like Brazil, places in Australia that have quite warm temperatures, suggesting that even when it gets warm in, say, the US, transmission is not going to go away not because there's no effect of the environment on the virus and no effect of the environment on people's behavior, but because the fraction of people that are susceptible to the virus is too high for that, plus the changes in the climate to limit transmission. So great question there. Yeah. So a few questions about seroprevalence. I want to go there. Let's see. Okay. Yeah, so I guess let's talk about antibodies a little bit because there's a few questions about that, and I think those are good questions. So, so let's talk about antibody tests and what they can and can't be used to understand or show and say. So I'll say briefly that there is a team of us at UCSC that are trying to develop high-capacity serological testing, led by a woman named Rebecca Dubois and Jacqueline Kimmy, and that antibody testing in general can do a number of things that are very useful. First, an antibody test could identify individuals at lower risk of infection and illness, but, and it's a big but, it requires a highly specific test, meaning a test that has few false positives, and especially when it's used in low prevalence settings, or otherwise most positive tests will be false. And I'll try to talk about that more in a second. And as a result of that, this kind of testing to identify individuals that might have immunity is most useful for people in high-risk positions where antibody prevalence is already likely high. So those would be places like doctors and nurses, maybe cashiers, Uber drivers, things like that. There is a widespread idea out there of, could we test people for antibodies? And if they have antibodies, could we then give them an immunity passport that allows them to go do either risky activities or engage in more normal life or things like that? So I will say that this idea of an immunity passport is challenging for several reasons. First, as I tried to make very clear, we do not yet have evidence that antibodies actually confer protection to the people that have antibodies. So there are not yet data that support the idea that if you have antibodies, you will be protected from either infection or illness. We all suspect that will be the case, but we do not yet have evidence that that is true. So that's the first major challenge to that. The second is that if we did allow people that had antibodies, especially from infection, do more activities, so either more fun activities or more economically profitable activities or things like that, that could actually encourage people to try to get exposed so that they then could get antibodies and then get an immunity passport. And that, of course, would not be a good thing at all. And so, so that's a second reason that I think the whole idea of having immunity passports is problematic. What we still can do with the tests that are out there now, the antibody tests that are out there, is we also, even if we can't carefully identify whether individuals are immune or not, and which individuals might be immune, especially in places where transmission has not been that intense yet, we can still identify the fraction of the overall population that's been exposed in a place, and we can identify subpopulations where transmission may have been higher. So we can screen a set of people and ask, is transmission higher or lower at in different ages of people? Is transmission higher or lower? Is exposure higher or lower? In, let's say, some professions than others, or in certain people that have maybe higher risk professions, that kind of stuff. So those are all ways that antibody tests can be used. And at the population level, even if the test isn't absolutely perfect, we can correct for imperfections. In contrast, at the individual level, imperfections in the test can be really problematic. And let me just give one quick example to try to make that clear. If a test is 99% accurate in giving not giving, say, false positives, right? So let's say that the test is 99% good and that only 1% of people that don't have antibodies will test positive. That sounds pretty good, but if you're in a place where the fraction of people that actually truly have antibodies is low, then if you give a large number of people that test, you're going to actually identify mostly people that are not that don't have antibodies, and you're going to tell them that they do. So the way that that works is to simply imagine if there's a test that's 99% accurate in false positives, right? So 99% of the tests of a person that's negative will be negative. That sounds great. The problem is that if you give 1,000 people that test, 10 of them will test positive just because of the false positive probability. And if true prevalence is 1%, then another 10 will also test positive because they actually have antibodies. And that means that of the 20 people that tested positive, 10 have it and 10 don't actually truly have antibodies. And that means only half of the people that you've told have antibodies truly have antibodies. So that's very problematic. It turns out that thankfully that this issue of basically many people being falsely identified as having antibodies, the probability of that is higher the lower the prevalence is and the worse the test is. I will say that there are 2 tests on the market now that have been developed and studied recently that have extremely high accuracy in this way, which we call specificity. The numbers are 99.9 and 99.8% specificity, meaning that only 0.2% or 0.1%, 1 in 1,000 or 1 in 500 people that are antibody negative actually show up as a positive in these tests. So that's very helpful and much more useful in identifying individual people that have antibodies. But let me reiterate again, we don't yet know if antibodies confer protection to infection. So hopefully that addresses some of those questions. And I think I have 3 more minutes, so let me see if I can get one more question in. A quick question is just about information being available about what's happening in Santa Cruz County, and the answer is yes. SantaCruzHealth.org is a website that the county has spent quite a bit of energy providing a lot of information about COVID-19 within Santa Cruz County. So folks that want to look at that should definitely do so. Let's see. Okay, so we do have a question about digital contact tracing, and I think let me take the last 2 minutes to address that. So, so as I tried to outline, a key part of the strategy for moving forward, where we're neither living our normal lives and having rampant transmission and lots of people dying, nor are we in a shelter in place where we basically can't engage in economic activity and can't be employed and have money to pay for rent and food. The third strategy is this one where we basically actively recruit people with mild symptoms to be tested, and then those that are infected, we find all of their contacts and try to basically get them to get tested and also isolate themselves and don't infect the people around them. So a key challenge in that is that if I find a person that's infected, the normal strategy is where we basically ask that person, in this time period over which we think you were infectious, who were you near in a close, sustained kind of way? And the standard metrics that are being used by most contact tracing people are, were you within 6 feet of someone for at least 10 minutes in a kind of unprotected way without masks? And so, so we try to identify all those people. And the masks or not masks is included by some groups, but not always others. So those are the criteria that are normally used. The challenge with that is that it's quite possible for you to have been in a place where you had sustained contact with someone, let's say for minutes, but don't know who they are, right? So if you're in a grocery line and maybe it was crowded for some reason, so you couldn't quite give enough space with people around you, and you were in a relatively small room, let's say, that meant that you had sustained contact with people for minutes in an enclosed space. So that would make you a relatively close contact. What if you don't know who they are, their name? How would we contact them? So that's a challenge. And the second big challenge is that sometimes if you got infected and got sick and then went to the doctor a couple days later, they might ask you, who did you have contact with 6 days ago? And the answer is, of course, you may not remember. So, so one technique that's been proposed to try to, let me say, sorry, one last thing. So even if we do have people, we have a list of people that we want to try to contact to get of these possible contacts that could be infected, we need to try to contact them and see if we can get them to isolate. And getting a hold of people is sometimes hard. So all those things I just listed, the possibility that there are contacts you don't know who they are, the possibility that you don't remember those contacts, and even if you remember and we can identify those contacts, successfully being able to contact them quickly and rapidly can be difficult. So a thing that's been proposed to address this issue is what's been called digital contact tracing. And the primary approach that's been being deployed in many places around the world, it's already been used some places, is to have an app on your cell phone that does one of two things. Either actually records a GPS track of where you've been, and then of course, obviously then we could, you could identify places that were risky and then try to tell other people that those are risky places and identify contacts that way. The other way that has gained much more prominence, I think because of the hesitancy with which to trace people's every move, is to have an app on your phone that would basically record whether or not other phones were within a kind of certain distance of your phone for a certain amount of time. And so again, the criteria that are being used are trying to use an app that would roughly identify people that were within a few feet of you for a sustained amount of time, like some sort of number like minutes, often minutes like 10 or 15 or some numbers like that. So the major fundamental challenges with that approach are twofold. One is that those approaches really only work if people choose to use them. And so the efficacy of those approaches scale with the fraction of people that, that would basically put that app on their phone and use it, turn it on. And so if, say, half the population uses it, then the efficacy of that is only about 25%, whereas if 100% used it, then it's 100%. So getting people to actually want to use that is a major challenge, and people have distrust in being tracked at all. And two, this technology can't know whether there's any barriers between people. So it could actually identify many contacts that are not real contacts. So there's been some challenges in, depending on the building construction, you can get detection of someone who's, let's say, separated by a wall between two people. So, so there are false positives that can be identified. But the major issue is really whether or not people would be willing to basically install an app on their phone and allow information to be exchanged. I will say that all of the ones that are being developed, especially that Google and Apple have been a part of developing, are ones where the information about which phones your phone has been near, that information would reside on your phone and would not be kind of instantly shared with, say, the government or any bodies like that. And so the way that it would work is that if you tested positive and there was a county health, a health agency that could verify that, that would basically, you would put in a code into the app, and the app would then send information to your contacts that your phone had been near in the appropriate amount of time for the appropriate amount of, in the appropriate amount of time that you could have been infectious for a long enough duration of contact. And it would indicate to them that they have been possibly exposed to an infected person and should seek a public health agency to get tested and see whether they're infected or not. So that's how those things would work. So hopefully that's effective. So I think now we're out of time, and I'm going to take just a 5-minute break, and I will come back for discussion after that if people want to have additional discussion. So thank you very much, and I hope this is a little bit helpful for you. To address another at least a dozen or two of those in the remaining time. Let me start with a couple that I've read in the break that I was just taking here. Let's see. So there's questions about whether the fraction of people, okay, yeah, thank you. So there's questions here about whether the fraction of people that will have no symptoms at all varies across populations. And the answer is that just like severe symptoms and death, which I talked about before, the fraction of people that are truly asymptomatic also appears to vary with age and is much higher in younger individuals and especially children. So there are some papers suggesting that a relatively high fraction of children may be totally asymptomatic. Great, so let me see if I can do. So there's a question here which, yeah. So about, is there a risk that a second infection could be worse than an initial infection, or that, put another way, could a vaccine actually cause you actually have a worse interaction? And so where that's coming from is that there are several diseases, excuse me, where initial infection confers some protection, but infection with another related virus can actually result in an even worse outcome. So, excuse me, for dengue virus, if you get infected with one of the 4 serotypes, that gives you protection against that serotype actually for life, but there's a window of time after which, if you get infected with a second virus, your chance of severe infection is even worse. That has not been reported for this virus, so we don't have any evidence that occurs yet. There was some concern that in vaccine development that might be a risk, because some of the vaccines that were being developed for SARS coronavirus 1, which was the virus that spread in Asia and to other countries in the world in 2003, in some lab animals we did see that effect, but so far we have not seen that in the studies that have occurred so far. So, so that's a possibility and a risk, but thankfully so far I have not read any papers that suggest that's a major risk so far. So there's questions about how long the infectious period is and the duration of sickness. And I will say that we know a little bit about that, but we don't have this definitive evidence as one might think. The data primarily comes in 2 forms. One is we, of course, have swabs from people's noses, and we can measure the amount of RNA in that swab, and that's been done dozens of times now. And that suggests that you actually can find RNA from people that are infected from before they get sick until as long as 28 days afterwards, with the probability of detecting that RNA on the virus decreasing over time. So it's quite high probability right around the time of symptom onset, on the order of 80 or 90%, but then it decays afterwards. And there's also some evidence that the chance of picking up the virus, picking up the RNA on the swab can differ depending on exactly how well the swab was put inside your nose. That doesn't yet answer the question, which is what's the actual infectious period? And so the difference, as I tried to make clear, is when we test for just the RNA, the pieces of the RNA with molecular techniques, we cannot differentiate the live virus itself from just pieces of RNA. And that means that these studies tell us how long you have pieces of RNA in your nose, not how long you were infectious. The data that we would like to address that question carefully are one of two things. One is we can actually look at whether contacts between people within certain amounts of time after they became sick result in infection or not. And in fact, that's this graph that I showed, which suggests that you were most infectious before you were sick, and then you were infectious afterwards as well, but the infectiousness decays with time. But those data are a little bit challenging to interpret because many of the people after they get sick go on to be tested and then are removed from kind of risky contacts with other people, and therefore we see less transmission. So the right side of that graph, the kind of many days after you become sick, we don't have super good evidence on your actual infectiousness because there aren't that many people that are basically at home, say 15 days after they've started being sick, having unprotected close sustained contact with their house members. So that's challenging. Second, there are very few, if any, studies that I've ever seen. Is this true? Yeah. So there are just a couple studies that look at actual virus in people's noses and what the relationship is between that and the time since they became sick. And those again suggest what I said, which is that the peak transmission or infectiousness is around the time of when you first start getting mild symptoms, so cough and fever, and decays over time afterwards. But the precise value of it would require us again to know the infectious dose, which we don't know. So that makes that challenging. I want to say anything else. Oh, I'll say one last thing, which is that the reason that we can't safely interpret RNA as live virus is because we have a number of studies now that are quite convincing that show us that people can be having RNA in their nose, be shedding RNA that way, and do not have infectious virus. And in addition to that, there was a very nice study done in a primate, a kind of experimental animal, where they infected the animals and then waited to see whether they developed immunity or not, and then actually challenged them again. And even in the initial infection, they showed that the macaques, the monkeys, were shedding RNA for a long time, but were shedding live infectious virus only for a few days. And so that's again suggestive that we shed viral fragments, pieces of RNA, for a long time, up to 28 days after we first get sick with this virus, but we're most likely shedding live virus for a much, much shorter period of time. But the exact duration of that has not been well defined yet. I would certainly, the data we have suggests that you certainly are infectious for a few days before you get sick, and certainly for several days afterwards, but whether that's 3 days afterwards, 5, 10, and exactly what the variation is around that, we do not have good data on that yet. Let's see. Yeah, so there's been another suggestion that, there's two suggestions. Let's see if we can take two of these questions at once. The question is there's two questions. So why can't we just, if we're all gonna have to get infected anyways, why don't we just go ahead and go with that? And then another idea is, if that's going to happen mostly anyways, why can't we just protect the people that are at risk of getting very sick and possibly dying, and then have the rest of us become immune? And so let me try to address both of those questions here. So what I've done here is I have, so the general question here is, can we pursue just all of us getting exposed and immune And wouldn't that shorten this time of having to wait for this vaccine from 12 to 18 months? And this idea and the words that people have used is called herd immunity. How far are we from getting to this place where enough of the population is immune that we can basically not have much transmission? So I want to show what that means in a picture, and then explain why this is not going to be a great idea. So the simple idea here is that if there's a new virus in a population where everyone is susceptible, basically no one's been infected before, which is the case with this virus, the virus spreads quite quickly, and that's shown by this picture on the upper right-hand corner here. As transmission occurs or a vaccine is developed and people become vaccinated, a fraction of the population becomes immune, especially if immunity actually does exist for that virus, and it does appear to be that case for this one, but we don't have good hard evidence of how effective that immunity is. Then the fraction of the population that becomes immune will increase, and at some point, either through infection or vaccination, you can get to the point, as shown in the lower panel here, this low right-hand panel, where most individuals are actually immune, and therefore, if there are some infected individuals, which is those little people here in red, even though there are still some susceptible people, which are the people in blue, they don't contact each other because most of their contacts, the people that they live and work with and spend time with, are in fact immune. And that's this idea of herd immunity. And there's this idea of a herd immunity threshold, which is that if the fraction of people that are immune gets high enough, transmission will be so inefficient that the number of cases will kind of fall over time and you really won't get sustained transmission. So that's the fundamental idea of herd immunity. And there's a secondary idea of there being this magical amount of the fraction of the population that needs to be immune before transmission is basically going to fade over time. So that's what would be nice if we could get there, and especially be nice if we could get there by vaccination. So we can ask, how far are we from this herd immunity threshold? And the answer is very far, unfortunately. I said at the very beginning of my talk that, that given the value of the reproductive number for this pathogen at the beginning of the epidemic, being about between 2 and 3 or so, we can use an average value of about 2.5. The threshold given that, and given variation among people, the threshold for herd immunity, this magical number, is likely between 30 and 70%. And the uncertainty in that reflects the fact that there are complex networks of interactions among people, and that influences exactly how you make the calculation. And there is variation among people and their susceptibility to infection. And the combination of those two that mean that even if we know the value of the reproductive number precisely, the exact threshold for herd immunity cannot be exactly identified. But the number is likely to be in this range. We can say, how close are we to getting to, say, 50%? And the answer is, there's been a bunch of sero surveys recently, these studies of looking at the fraction of people that have been exposed, have antibodies, and hopefully, let's be super clear, hopefully have immunity, but we don't know that yet. Of all these studies, the closest is in New York City, where about 20% of people that have been screened for antibodies have antibodies. Several other cities are in the range of 8 to 12%, and these are cities you probably heard of, like Madrid, Paris, Geneva, places like that, where transmission was relatively intense. Unfortunately, because these numbers of all these places that have been looked at, I should say there's a bunch of other places where the numbers are much lower. Because these numbers are a far cry from 50%, if we wanted to get to herd immunity simply by transmission and not through a vaccine, then we would result in a bunch more people being infected, and unfortunately, a bunch more deaths, unless we could somehow shield all of the elderly and risky people. And so without successful shielding, which I'll talk about in 1 minute, the number of deaths we'd see, you can simply get at by taking the ratio of herd immunity, which we can estimate as crudely 50% between this kind of range here, and the actual seroprevalence now. So for example, in New York, about 20% of people have antibodies. Herd immunity, if it's about 50%, that means we'd need basically 2.5 times more infections than we've had so far, which would result in a total of 52,500 people dying just in New York City. So New York City is a long way off herd immunity, the herd immunity threshold, and everywhere else is further. And that indicates to me that we do not want to pursue this strategy via normal transmission. So the second question, which was what was just asked in the Q&A, is, oh, sorry, there's one more piece to this. So one more reason that we don't want to literally just go back to our normal lives and let the virus sweep through is that not only would we get substantially more deaths before we get to herd immunity, there's an additional terrible thing, which is called this idea of overshoot. And that is that even if the herd immunity threshold is, let's say, a number around 50%, which is what I've, or 60%, which is what I've written here, if you let an epidemic get really, really going, even once you reach that herd immunity threshold, there are so many infected people that you basically get some additional transmission afterwards, even though the number of cases per case is less than 1. So for example, there's a graphic here that was done by some colleagues of mine, whereas the fraction of the population that's becoming infected rises, that's this red bar underneath here, even once the fraction of people that are no longer susceptible decreases and you get to herd immunity threshold, there's still all these infected people at that time, and they lead to a bunch more transmission. And the result of that, which some of us have called epidemic momentum, leads to this overshoot where a bunch of extra people get exposed, and the fraction that eventually get infected is actually much higher than the herd immunity threshold. So for example, under kind of some simplistic mathematical assumptions, if the herd immunity threshold is 60%, due to overshoot, you'll actually get about 89% of the population exposed. Now, if we build in a little more realism into the model where we actually account for heterogeneity among people and susceptibility and contact patterns and network structure, if the threshold is in this kind of more realistic range of 30 to 70%, the concept of overshoot still applies. So that's why even if we eventually do get to herd immunity by infection, we don't want to get there in kind of a raging epidemic. We'd be much better off getting there in as limited way as possible. Finally, we can ask, why can't we just quarantine the older or at-risk people and let the rest of us get infected? This has been raised many, many times, and so I want to kind of address it head on. And the answer is that severe illness from COVID-19 occurs in people older than the age of about 50. And I can show you exact data before I showed it to you a minute ago, but that's the age category where severe illness and death really kicks in. In the US, 100 million people are older than 50 years old. So that's a huge fraction of the population. You might say, okay, let's accept some more death and just try to sequester or protect or shield 70-year-old people and older. That turns out to be a smaller number, of course, but it's still 31 million people in the US, and that's about 10% of our population. Given that if we did try to take this strategy of letting the virus kind of sweep through the population to get the rest of us immune, that would take about 3 to 4 months with a peak period of 1.5 to 2 months. That's a very long time to somehow provide safe care to 30 to 100 million people. And the data we have so far is that it's simply not possible. We've actually done a relatively poor job of protecting people in elderly care homes, which is a tiny segment of that older population, and yet we still haven't protected them. So the idea that we'd somehow be able to safely isolate or quarantine 30 million people for a 3 to 4 month period is simply not possible. And if we failed, which is almost certain to occur, it would be disastrous. We'd get widespread transmission and deaths, as I've outlined before. So I hope that helps address that question. So let's see if I can take a few more questions here. So there's a question about some of the comorbidities. And so I will say that there's a really nice study on a huge population from the UK that looks at the chance of death given that they kind of get sick and come to a hospital in the first place, or to a doctor in the first place. And most of the morbidities lead to relatively small effects relative to age. So there are 3 or 4 comorbidities that have really substantial effects, and I mentioned those previously. Those are severe diabetes, some forms of cancer, and things like that, whereas the more mild, differently, some of the other comorbidities have some effect, but the effect is much smaller, and often basically on the scale of just say a half of a decade of age. So definitely it is worse for people with some pre-existing conditions, but if you're an older person and have no pre-existing conditions, that means you're definitely still not safe at all. That the effects of age are much larger than the effects of pre-existing conditions. I addressed one of these questions briefly, just to say that the antibody tests are very, they're highly variable in quality. There are a few by 2 companies named Abbott and Roche that are very good at, if it says you have antibodies, the probability of antibodies is quite high. They have very few false positives, on the order of 1 per 1,000 or 1 per 500. There are also pretty good at identifying whether you have antibodies or not. So that probably is also, those tests are also relatively good, but there are many other tests out there that are not nearly as good, and those can give you definitely bad information. That addresses a few of those. There are questions about, is there ways for us to reduce the chance of dying given that we get infected before we get a vaccine? And the answer is yes. We're trying to find drugs that will do that. There have been several drugs tested, and there are several drugs being tested now. The one that's shown the most promise that I've read about, unfortunately, has not been one of the ones that the president is most excited about. Both the main things he's been promoting actually have not been shown to be effective and have actually been shown to be harmful. But there is one antiviral that's been tested that shortened the time that people spend in hospitals by about 4 or 5 days. So I think it was from 15 to 11 days. The same drug appeared to reduce mortality by a little bit, but the effect size was small enough and the uncertainty was wide enough that it would not quite meet our normal threshold for being different than chance, but it was certainly promising. And unfortunately, that study was stopped before it was allowed to go on further to really identify that protective effect on mortality, because they wanted to give the drug to the control group. And that's actually frequently done in tests of efficacy for drugs. Let's see. There's a couple questions about are other tests besides the ones where we stick this Q-tip really far up our nose good? And the answer is that mostly. So there's a relatively widespread use now of either just a swab in your mouth, not so much back down your throat, but actually just one that you could administer yourself, or using spit or saliva. And actually several countries are using these for their main testing of visitors and things like that. And the data from science suggests that those are pretty good. They're not quite as good as the kind of swab in the very back of your throat, especially from your nose, a nasopharyngeal swab. Those are the most accurate that we have of the 3 swabs that we normally do. But the difference in sensitivity, the difference in the chance of kind of missing an infected person is small enough that that's more than made up for by the ease at which people can do those tests. So those are, a lot of places are moving to those tests. Let's see. So there's a quick question I can address relatively quickly, which is, what's the likelihood of a second infection wave? And the answer is that's completely dependent on 2 things. Well, primarily, yeah, 2 things. One is what is our human behavior? What do we choose to do in terms of opening businesses and our activities and our habits and gathering in groups in unprotected ways? And how effective our public health infrastructure is at keeping overall transmission low. So I will just say that if we go back to our normal lives and there aren't things in place to basically keep the number of transmission events low, we will definitely see a large second wave. And the timing of that could be modulated by things like weather, but it will be even more importantly modulated by our own activities, behavior. Let's see. There's a few moderately controversial statements in here that I am hesitant to tackle. There's a quick question I can answer here, which is, are there evidence for any vitamin supplements or things like that being effective? And the answer is no. There are a few provocative claims, but no actual evidence to support any of them. Yeah, so just to reiterate again, I said it before, but it's such an important thing. There's questions about, can we test someone and find them to be negative, and then test them again a few days later and find them to be negative again? And will that tell us safely that they're uninfected? And unfortunately, the answer to that is that there are no data to support or test or refute that idea one way or the other, despite repeated requests from many of us to collect that data. So the data do exist. It's not been collected or analyzed in a way that any scientists have made use of it yet, despite everyone recognizing it as a very important thing. So that's actually something that I'm hoping to work with our local county to see if we can get some data on. Another quick question, how can we most safely get people to be tested? And the answer is twofold. One is people have probably heard of drive-up testing. And so that's certainly a very effective way for people to come up in their car and not have to go into an enclosed room with other people and with doctors and nurses, and simply just get swabbed from the window of their car. That's being done and used a lot. And the second way is, as I mentioned briefly a minute ago, people are shifting to the use of less invasive tests where we basically would either spit into a little receptacle or take a swab and put it inside your mouth, or even rub it in your nose and your mouth and just submit that swab. We do know that both of those other kinds of tests are not quite as good, but again, if they're so much easier to do and so much less risky for everyone, the benefit of that may outweigh the other one, and many organizations are switching to that. Let's see. There are so many good questions. This is interesting. Okay, so I guess there's a couple quick questions about masks. So let's just recall that the primary, most effective thing about masks is not protecting you, but protecting everyone around you. And so, so that tells you a little bit of something about, like, is covering your eyes as important as wearing a mask. So certainly it is the case. There is data suggesting you could become infected by the virus, let's say, reaching your eyes and then going into your body that way. The risks for that are lower than you breathing it in. So that's a possibility, but not a high risk thing. But again, the probability of that occurring certainly will increase with the amount of time that you spend in an enclosed space with a person in close contact. And the disinfection of masks is a challenging thing, but not impossible. So certainly the more frequently you can wash them, the better. And all the ways of washing them, there's ways of washing them from least effective to most effective. And so most effective, of course, would be washing them with some sort of soap and good rigorous washing, versus a rinse is going to be less effective, but still better than nothing. There's a number of questions here about, can we do certain things like massage or haircuts or things like that? And the answer is those are all possible, but carry substantial risks. And the risks of that all increase with the factors that I tried to mention before, which is the proximity of people, how close you are to people, whether there's a barrier between you, and that means a mask for both people. Both people wearing a mask will reduce the kind of spread of droplets. And what else did I want to say? Yeah, and the ventilation and the closed space around them. So if those events could occur basically either outdoors or in a well-ventilated area, that's going to reduce the risk as well. So those activities obviously include being very close to the person. There's no way to give a haircut or give a massage without being very close to a person. So that's going to be relatively high risk, but the risk of that can be diminished substantially by doing that outside and by both people wearing masks. The virus survives very poorly with direct UV sunlight. So directly exposed objects to the sunlight are going to be disinfected by the sun relatively quickly. But of course, an object in the shade doesn't get to have that benefit. So that's a small possible risk. Let's see if there's any things we can. A couple quick questions. The turnaround time of some tests. There are some tests on the market by commercial manufacturers that give results within minutes, just 5 to 15 minutes. And those are useful, but not quite as accurate as tests that take longer, like a couple hours. And so there's a little bit of a trade-off, but those are definitely being used in hospitals and doctors' offices. And certainly those can be very effective. And if they give a positive result, that's a relatively accurate thing. If they give a negative result, it's not quite as accurate for the reasons I mentioned earlier. What else? Oh, I guess I'll quickly address this. So there's a big little bit of conspiracy going on about whether or not the virus could have come from a lab, or did this just come from a wild animal or something like that. And there's extensive evidence that I don't have time to discuss in great detail, but to suggest that this virus did not come from a lab. It almost certainly came from a wild animal. The best guess, without hard evidence, is it might have come from a bat, just in that the most closely related viruses came from bats. But we do not have an isolate of a virus coming from a bat that's very closely related to this one. So it's actually also possible that it came from a different animal. And it's also possible that even if it came from, let's say, a bat or some other animal, that it got to people via a secondary species. So, so a substantial amount of evidence, although not absolutely definitive, suggests that the virus may have spilled over into people at a live animal market in China. And if that's the case, we do know from other studies of other viruses that often you can get mixing of viruses between different animals. And so the virus, the animal that gave it directly to a person could have been either the original reservoir for the virus, or it could have been a different animal. So for example, the first SARS coronavirus 1 in 2003, we now know that viruses that virus basically extremely likely came from a bat species, but there's decent evidence that it may have gotten to a person via spillover from bats into some domestic animals that are eaten for food and fur in China, especially called civet cats, and that it's quite possible that people got it from a civet cat that got it from a bat. Let's see what else. So just quickly, there's a question that asked about why has Santa Cruz been lucky with respect to COVID-19? And the answer is because we, as well as some other counties and places in California, we took relatively strong measures early on when infection prevalence was very, very low. And this is a big and, we got a little bit lucky in that we did not have any super spreading events in our community early on. So there's now very, very good evidence that that even though we have an average reproductive number of the pathogen for between 2 and 3, about 2.5 cases per case in a normal, kind of in our normal life scenario, most people don't go on to infect anyone, the majority of people, but some people go on to infect many people. And we are basically just lucky that we didn't have an infected person come into an enclosed space with a bunch of other people for a sustained amount of time, like minutes, and go on to infect, say, 50 people in Santa Cruz, which then would have gone on to infect their household members, their friends, their family, and things like that. That would have led to a large outbreak. And we were fortunate not to have suffered from a known large outbreak, especially early on in transmission. Let's see if we have time for a few more questions. Just quickly, because I can answer it fast, there's a question about, is there RNA actually in poop? And the answer is yes. And not only that, it's actually easier to detect the virus in poop than in any of the other respiratory swabs that we have. There's a very nice paper that just came out on that and suggests that that's actually a quite good way to detect the virus. But of course, that's a slightly more challenging way to sample a person than some of the other swabs. So I have not heard about any public health efforts to switch to that as the major way to test people, but it definitely is a relatively effective way to find RNA of the virus if people are infected. So good question. There's a quick question that I can try to address. Sorry, there's a question I can address relatively quickly. The antibody tests, which other words you've heard for that are immunoassay tests. The question is whether or not they can identify, let's be careful. Yeah, so there's a question here asking about whether tests that look for an antigen rather than, say, RNA can be used. And the answer is yes, and there's been a couple tests just recently developed, and they're now being rolled out in some places. So those will also be used as we go forwards. Yes, so there's also a nice question here, which ties on with another question we've briefly mentioned before, which is, could we help get back closer to normal life faster if we had a treatment before we get a vaccine? And the answer is yes. I think if we had a very effective drug treatment that we could use to reduce mortality, and we believe that that was a good way to go forward to basically have some more economic activity, that might be a possibility, but there are no drugs that have been studied and shown to be efficacious enough yet that that's a strategy that we can employ. So the drug I mentioned briefly before has been shown to slightly reduce mortality, but not in a strong enough way that we can be confident in that. And the main effect that was demonstrated was a shortening of the hospital time, which is very useful, but again, not the main outcome we really want is to stop people from getting sick at all and stop people from dying. And it's not been yet shown to be effective enough for that. Let's see. So there's some questions about a number of questions from people about why is there so much variation among people in the outcome of infection, so the chance of getting sick and dying, and the answer I'm going to give is going to be not wholly satisfying, except to say that for everything that we've ever studied as epidemiologists or disease people, there's always variation. And for many diseases, not all, but many, and maybe even most, older people suffer worse. So that's true for influenza, it's true for COVID-19, it's true for many other things. For this disease, there was one correlative paper, and again, it's just a correlative study, so take this with a giant grain of salt, but that maybe there's different, I'm not even gonna say it. Yeah, it's indirect enough that I don't think it's a way to base any strong conclusions. Any last questions? Yeah, so I think I might, I'm supposed to be here till noon or so, and we have a few minutes left. Let me see if I want to share any. I put a bunch of other slides together, and let me see if I want to try to share any of those things. I think I've addressed most of the relatively straightforward questions. We did herd immunity part, which was good. We did that part. We did the masks. We did the seasonality part briefly. The Moderna vaccine, I think, is not crucial. We did the serology stuff, which is great. We talked about that. There's big questions about what's going to happen next, and I guess I'll spend the last maybe just a few minutes talking about that. And there's three major issues here that I want to try to address. The first is that if anyone tells you exactly what's going to happen in your small town, they're just making it up. So we have enough evidence now that suggests that the variation in transmission, and especially what I talked about before with this, I think, amazing phenomenon where each person that's infected, the majority, more than 50% of those people will often not go on to infect anyone, but some people will go on to infect many, many people. That variability we see and the probability of these, what we've called super spreading events, make it so that the outcomes are relatively unpredictable, especially in relatively small towns, but in larger cities, they're more predictable. So, so that means that understanding what's going to happen in Santa Cruz County, whether we're going to have a huge flare-up in cases, let's say 2 weeks from now or not, I would not be able to make that prediction with any sort of real confidence. But I would say that if we return to normal lives in cities, I can with almost certainty guarantee that we will see an increase in transmission and a rise in cases quite quickly. So let's say that part. And obviously, as I've said many times, if we have large groups of people interacting in ways that spread the virus, we're going to get lots of transmission. In contrast, our behavior matters. We can minimize the chance for a big event and the ripple effects that happen afterwards. So if we get together in a large group, not only do we have the people that are in that group could get infected and probably would get infected, but those people will then go home and infect their housemates or partners or family members who didn't even go to that large group. So it's not just whether or not you partake in a risky event, it's obviously then afterwards, if you get infected, who else you might infect in that process. So that's important context. And then let me say a couple of quick things about the challenges in assessing what's the impact of opening or lifting lockdowns. So one of the big challenges that happens with this disease is that there's substantial delays that make it tough to know what's happening. So if the shelter in place is lifted and transmission increases, we can ask how fast will we know? What would we use as indicators? And the first thing that you could do is just look at the number of cases that you're seeing. But if we're just using passive surveillance, the normal things that most places are doing right now in the US, we wait for sick people to go to doctors or hospitals. There's challenges with that. One, because if we change how many people we test, we change our testing capacity, which is happening everywhere. We're getting more and more testing capacity. Then we'll see a large number of cases, even if infections don't change. So that's problematic. In addition, people normally don't seek out healthcare until they've been sick for almost 2 weeks. So there's a big delay that way. If we count the number of hospitalizations, that's better. It's less variable than the number of actual people testing positive because of variation in testing capacity. But again, we have at least a 14-day delay. So that's not great. If we count the number of deaths due to COVID-19, that's actually the least variable, which is great. But the time from infection to death for COVID-19 is on average 27.5 days. So almost a month. So if we use the number of deaths as our criteria for whether transmission is going up or down, we'll have to wait a month to find out. So that's terrible. There are some other options, thankfully. So some places are using what's called syndromic surveillance, where we actually use reports of people of their illnesses, often via a website or a mobile app. And that can be useful, but it relies on accurate and voluntary reporting of people that report their symptoms. And if we obviously have a change in the number of people that are supporting their symptoms, then that will obviously mess up all the numbers. So that's problematic, but can be useful. Lots of people are using measures of mobility via how much our cell phones are moving around. And I will say that that's been quite highly correlated with transmission rates before lockdowns were imposed. But there are papers showing that it's possible for that correlation to go away after lockdowns are lifted. And that's likely occurring because we're starting to move around more. But if we use good social distancing behaviors like 6 feet of space between us, masks, washing our hands, that kind of stuff, those correlations go away. So I think mobility has been a great tool in the past to look at things and may be useful going forward, but the correlation may be much weaker than it was in the past. Finally, the third approach that has been proposed and I think could be quite effective is that if we actually use actual SARS infections via testing, but we count those by having an active surveillance program and even probably have a screen of a set of people that are actually asymptomatic or healthy, especially of high-risk groups. So that could be healthcare providers, or it could be high-risk professions like cashiers or taxi drivers or things like that. That could basically give us a population that we're monitoring. And if we're doing it of sick and healthy people, we can pick things up before sickness occurs and reduce that delay between a spike in transmission and detecting that spike in infections. Okay, so unfortunately, there's no easy solution, and it will be difficult. And as a result of that, we may see actually a spike in cases that might have to result in a reclosing of some businesses that led to some rapid transmission. I think, yeah, so that's that part. I wanted to go, I think in the last few minutes, there's still a few people on the webinar to talk about mathematical models that are making predictions about what's going to happen, because these have played a really large role in the overall response to this, and people are going to be seeing these going forwards, and I wanted to give a couple tools for people to kind of best interpret those models. So I basically want to give you a tool to assess whether a model that you're seeing or a projection you're seeing is good or bad. So the idea here is that there are many, many model predictions and projections for COVID-19. The main goal of most of these projections and predictions are to compare different scenarios and to use the outcomes of those projections to plan for capacity for things like hospital beds or PPE. So the first recommendation I want to make is that if you see a model projection, the first thing you should ask is it telling you up front what its most important assumption is, which is what's the scenario? And so, for example, on this slide, which is the website of one of the better modeling projects that I know out there, modeling teams, they show you two maps, and they've basically made projections or predictions, one with unmitigated projections. That means basically normal life scenarios, how many cases there are going to be. And so the darkness of the map is the average number of infections projected. So that's if we basically have our normal lives back. And then there's also a prediction made if we have social distancing in place. And you can hopefully, of course, see that the map on the right is lighter, suggesting that social distancing is quite effective, and the data are very supportive of that. So the first thing you should ask if you see a projection is what are they modeling? Are they modeling conditions under which we have our normal lives back, like this, or are they modeling with certain things in place? And the model projections are going to be only as accurate as the world is in terms of the assumptions that are being made to build it. So if they're modeling social distancing and we lift social distancing, then these projections are going to be wrong. And by the same token, if they're modeling normal life and we don't have our normal lives back, those models will also be inaccurate. So that's the first thing. The second thing is you should just ask, does the model make sense? So the White House actually presented this model that's in the lower part of this graph that had some puzzling projections. And so the idea was that the black line was the number of cases we'd seen over time, and these spikes that might kind of, you might wonder what the heck's going on, and that is simply that the reporting of cases varies over each week. There's something called the weekend effect, where often cases are not reported on weekends. That leads to these spikes. So there were several models kind of fit to these data and made projections in the future, and some of these models made extremely optimistic projections. So for example, both this dashed brown line and this red line, which the dashed brown line is a model by a group in the University of Washington. And that suggested that there's going to be a rise in cases and then a fall in cases that would go actually to zero sometime at the end of May. And then this cubic fit, this red line, which was actually done by an internal White House part of their team, suggested that cases were going to go to zero even faster. I should also be clear that the data extended to here, and so these models were the projections were made before that time. So this red line suggested the cases were going to go all the way to zero and just magically go away. So that's fantastic, right? Except you can ask, does that make any sense at all? Why would the cases of coronavirus drop to zero? I should say these are deaths per day. Why would the number of deaths per day magically drop to zero on May 16th? What's magically going to happen then? And the answer, of course, is that that didn't happen, and that model was really not reliable and shouldn't have ever have been believed. So just on the bottom graph now, I'm showing the projections of the models for this period in kind of early May to late May, and here are cases across the entire US. I'm sorry, these are deaths per day in the entire US, so it's the exact same data shown on the y-axis here as here. The actual data are shown in the red boxes, and of course the cases did not magically drop to zero. They are decreasing, which is good, fading over time, but they're not going down quite nearly as fast as any of these three lines down at the bottom here. So if you see a model projection, ask, Does it make any sense? Or does it, if it doesn't make sense, then you probably should discount it completely. Okay, so the third way to spot a bad model is that if the model is making projections really far into the future, then it should have a huge amount of uncertainty because we really don't know what's going to happen far in the future. So if I saw this picture here, which is actually the website I took a picture of yesterday, and it has the kind of daily counts of estimated infections on it and the number of tests that are going to be done, it's making kind of predictions about what's going to happen in kind of June, July, and August. And yet the predictions that it's making, which are these kind of dashed lines here, the uncertainty around them is actually quite small. So this model is saying that these people that built this model think that they know what's going to happen with relatively high levels of confidence in July and August. And I simply think that that's not possible to do because we don't know what's going to be happening in July and August. So I would say that I would not believe this model at all because I don't think that the uncertainty this far out should be much, much higher than that. And what's also crucially missing from this picture here, which is not very clear on the web page itself, is what scenario are they modeling? They're not making it super clear whether or not they're modeling an opening up of the lifting of the lockdowns and opening up all the businesses. Are they modeling with the shelter-in-place orders in place? And if so, we might expect the cases to continue to fall. Whereas if we open a bunch of businesses, of course, the number of cases are likely to rise again or at least flatten out. And yet this model is not showing us those things. So again, I would not believe models that are making predictions with high certainty about things that simply we cannot be that certain about. I think I'll probably stop that part there, although I had some slides about this model that kind of changed how all of us were dealing with COVID-19. Let me see if there are any new questions that I didn't address that came up. I think I'll go ahead and stop there. So, so thank you everyone for coming today. And I hope this was a little bit informative for answering some questions and also giving you some tools to try to address information as you see it coming forward. So with that, thank you very much. And we'll call it the end of the day.